All right, so good morning, everybody. For those of you who don't know me, I'm Carolina Benjamin, and this morning I'm going to be talking about gamma knife radiosurgery for vestibular schwannomas, indications, techniques, and outcomes. I think this is a hot topic. This comes up often at our M&M. It's a hot topic at our skull-based meetings and our national meetings, so I think this is an important topic to look at the data and really what does this conversation look like in the office. And I think especially for the residents, you see, what patients go to surgery, and certainly we talk about certain complications, and then we talk about the indications for radiosurgery, but you don't really see this conversation. And I'll tell you, this is about an hour-long conversation with each patient. So, and I think all of us who do skull base here in this group, we do both radiosurgery and skull base. So we talk about this with every single patient. All right, so those no relevant disclosures to this talk. These patients in particular are very educated patients. They're patients who, they have the luxury of time. Acoustic neuroma is not anything that's urgent. So when these patients come to you, they're very, they've looked at the internet. They often have gotten second opinions at other places, and they come to you with really good questions. They ask you, what are your options? Everybody's read about the gamma knife. People have read about CyberKnife and Linac-based radiosurgery. They have knowledge about what the risks can be. They want to know some important things. What about my hearing? I want the best facial nerve outcomes. I want my tumor to go away, and I want my hearing to be perfect. And that's sort of what they come to you with. So it's a tough problem to address. And the only way to really do it is to keep the patient as informed as possible. So this is from, there's a huge amount of literature on this. This is from 2017, from the British Medical Journal. It was asking about what intervention really is best practice for vestibular schwannomas. This has been talked about for a long time, but the group coming together and determining what the true recommendation, what the best practice is something of more recent. 2013. And this was the best data that we really had at the time, trying to focus. And it sort of was where some of that traditional teaching of, tumors smaller than 30 cc's is a best practice for, if you do radiosurgery for those. That's all we really had then. And then in 2020, this paper came out, this modified Delphi study, and it sort of if you look at the authors in this group, this includes both ENT and neurosurgeons. I think there is also radiation oncology specialists and people who are really the experts in the field. And then if you look at this paper, and I often actually refer my patients to this paper, because the interesting thing about it is it'll give you a statement. And then it sort of tells you how many of these experts agree. And so then it comes up with almost a consensus statement telling you, okay, this is a strong recommendation because there's agreement amongst all the experts or not. And the way that the study is done is that, they really went back and forth with the recommendations. They were sent back and forth it was almost like a discussion type of paper with people arguing with each other to try to come up with what are we going to tell people that we recommend. And if you read one of these statements in isolation, they actually can sometimes contradict each other. So you really have to take the whole package as a whole. And I think the beauty of this paper is it really highlights the controversy and the fact that there are certain things that there is no right or wrong answer, but that this is a big debate, and different places do it differently, right? If you go to Canada, nobody's operating on certain size acoustics, and if you go in the US, it's very different. So I like this paper just because it really highlights the fact that this is a difficult topic to address. And I always tell my patients to read, and I think for the residents, I think it's also useful for you to read something like this. It really will get you to the key points. So really, what's the natural history? What's the role of observation? In order for us to be able to tell somebody, yeah, you should just continue to observe this, we have to see what happens with observation, what the natural history of it is. So some of the data that came that recommended the recommendation for natural history came about because there were articles that looked at the conservative management of these. And, we had data to show that, well, the growth is really slow. You have this mean growth of 1.5 millimeters, plus or minus 2 millimeters a year. And just 10% had greater than 3 millimeters of growth in a year. And less than 3 had 87% had less than 3 growth. Okay, so if everything is growing very little, then perhaps the recommendation to observe is actually the best recommendation out there. So this is where the data was coming from, that, we get the traditional teaching of that 3 millimeters of growth a year. And I think this data had, this is coming out of Paris, this is coming out of France, and this is, it had good value, but it was limited too, because as we all know, we all have this patient, which this is 2004 here on the left, 2009 on the right, and you have a tumor of this big, they get lost to follow up, whatever it may be. If the growth rate really was 3 millimeters a year, or 1 plus or minus 2 per year, you're not really, this is much more than the expected growth rate. And if you can see here, this is this person's audiogram, very good hearing. So we all have that patient that is an exception to the rule. And so this sort of made people a little bit more curious about looking at the data a little bit more to see what's the true natural history, and are we reflecting the true natural history? So this started to look more about it. Okay, so this was a paper that came out of Denmark in 2006. This was an observation period as long as 15 years, which is pretty good, right? So this said that 17% of the intrameatal tumors grew, and 20%, and then 29% of the extrameatal tumors grew. But if you look at it, what their definition of extrameatal, intrameatal was actually very different. So I think they're actually defining what the intrameatal, extrameatal extension differently than what we define it as today. So then, perhaps the findings of these papers are not necessarily going to be what we can use, because the definitions just don't match up. So then we have this 10-year follow-up on tumor growth and hearing in patients with intracanalicular vestibular. So it says tumor growth only occurred in a minority of the patients. If you look at here, out of the 325 papers patients that they looked at, 50% of those were excluded, right? So that's already taking out a significant number. And again, the Denmark, a lot of the data on vestibular schwannoma comes out of Denmark, because they have a very had a homogeneous group, and essentially when they were there, all the patients with vestibular schwannomas would go to a certain hospital. So it almost got funneled into one place, and they were able to collect a lot of data on this. So again, 50% of patients were excluded. And then this is another study looking at, this is again out of the Norway group, 45 tumors that were initially observed. And then again, they came up with this volume doubling time of 13 years. So this is again getting to the fact that this is a slow growth, and perhaps that we should be watching this, right? The unique part about the Norway group, again, this is all controlled healthcare system. All the tumors were seen at the single center. So this included the tumors that were treated with SRS, but only after having been observed first. So these are tumors that they actually showed the natural history because they were observed first. So they looked at it before it was treated. So this is sort of where the data originated about we should really just be observing these tumors to begin with. So that's all some of the old data, and you can see that there's problems with the definition, and there's problem with homogeneous populations. So I think we needed more updated studies on this, and this is a paper that came out of NYU looking at the volumetric growth rates of vestibular schwannomas. So just to show you some examples here, you can see an example of growth. So 67-year-old man, he has got this left-sided vestibular schwannoma. This is an initial up and then a follow-up in 9 months. If you look at it, if you just look at this picture, and there's always some differences between one MRI and another, this may have been interpreted as slight interval growth. And, the radiologist may read it as such because they're looking at it on a single, like a one-dimensional axis or even two-dimensional axis. They're not really measuring the volume of this. But if you actually go through and you measure the volume per slice, this represents almost 400% growth per year. This is a fast-growing schwannoma. So it's important to note that not, a radiologist may call this, mild growth, when really it's a dramatic growth here. So it's important to keep that in mind. Here's an example of stability. Again, there's an area here that's more hyperintense than the other. So, perhaps the radiologist may even miss that and call that some growth. But really, if you look at the volume of this tumor, this is a relatively stable tumor. So anyway, this paper, the ultimate goal of this paper was to show that there are differences in the growth patterns that we're not really appreciating the subtleties of, because the measuring was not being done as you actually accurately as you can, which is to measure volume. So this is what this paper did. So this graph here shows tumor volume in cubic centimeters on the y-axis, and then time in months on the x-axis. So every one of these lines here represents a patient, and then the colors actually indicate what growth group they fall into. So you can see here that the orange is stable. The red lines are the tumors that are growing. And then you have the blue lines, which are tumors that are fast growers. And then you have two tumors that actually spontaneously shrank. Again, this is similar to the previous study that was done out of Norway, in the sense that these are all untreated tumors. This is why it can speak to the natural history, because these tumors have all been untreated. So you can see that there's a range of initial tumor sizes, of the amount of time followed, right, which is in the x-axis, and then in the slopes. So there's differences in the growth rates, which is what the slopes represent. And then just so you know, just go back there, the fast growers, the ones in blue, are the ones that grow by 100% increase volume in a year. So that's significant growth. And you can see here in this graph on the right side that, again, here's the small amount that shrank. 33% are stable, right? But look at this. This is a surprising finding, I think, for most of us who do this. 66% of tumors grew, and 30% of those were fast growers. I think this is a lot more than what was anticipated if you looked at those studies that we just looked at, which is showing that, well, if they're growing just 87% are growing less than 3 millimeters a year, that's not significant. So I think that there are some significant problems with those studies, which drew those conclusions, and they were perpetuated over time. So this study really allowed for almost like an update in the true natural history of vestibular schwannomas. This is sort of a complex algorithm to get this, because it's looking at the linear. You have to get the natural logs so that you can the proportional growth could be assessed rather than just absolute growth. So it's a little bit complicated, but out of this regression, you actually get a growth rate per year, which is 33% per year. So I think that's pretty significant and just surprising, I think, to most of us. And then you can see here on the right side that in this paper, these are the patients that eventually went either for resection or radiosurgery. So patients who eventually needed treatment. And that's after 1 year, 36% of patients, 2 years, almost 60. And then after 3 years, the majority of patients went on and got some form of treatment after observation. And so then that came out of NYU. And then this was a study out of the Mayo Clinic, which also has a high volume of vestibular schwannomas. And you can see that they actually had very similar findings. So it was consistent. Again, this is an example of how they measured this to show that they were not measuring this in a linear fashion. They were measuring volumetric analysis. And they're saying that a significant proportion of vestibular schwannomas, 70% in their group, had a demonstrated growth during this observation in untreated tumors. So, this has been validated now. And I think we've gotten to a point where I think most of us are able to tell patients, when they come to us, rather than saying, no, this is not going to grow, we can probably confidently say with this data that, yeah, the data does show that these tumors tend to grow about 60% of the time, 30% of time it being a fast grower. So that was really kind of a big change. And then, so there's some tumors that grow a lot, and then there's some tumors that grow a little. So, this is a tumor that's, measuring here only in one axis and the axial diameter here, but it's growing from 8.3 to 11.9. So volumetrically, this may actually show a difference that is more significant than we expect on this linear axis. But the important thing to notice is, okay, you would not necessarily expect this is still a small tumor. What's the hearing like? Well, guess what? 92% speech discrimination. And then, in a period from April to October, the hearing's lost. So how do you predict that person? Why is that? And why do people lose their hearing? Is it a vascular? Is it that the tumor grows bigger and there's some sort of change in the protein content? Is it, direct compression? So there are a lot of different theories, and most likely it's a combination of things, but this, sort of makes us stop and think about that. So this is a study looking at long-term hearing outcomes following radiosurgery in acoustics. And, this study in particularly says our data does not support a proactive strategy of radiating vestibular schwannomas at the time of discovery, right? Because so if you go back to this patient, is this supporting that, well, if they had been radiated at this point, that they could have kept their hearing? So that's what the studies like this look like. Should we just be going ahead and radiating that? And this study said, no, we really shouldn't. They were pretty, like, that was a pretty definitive, conclusive statement that they made. I think one of the big issues in this study is they didn't even mention cochlear dose, and we'll sort of go over that a little bit more later. But that's an important determining factor, is that they didn't really talk about what the dose of the cochlea, was getting in this paper. So here's another question is, so we looked at what's the volumetric growth rate, right? That's what the last study out of NYU looked at. And then here's another study that is looking like, all right, what about the patients that we are observing? We now say that the 60% of them are growing. What's happening to the hearing? And this study does show that two things affect the hearing, not only initial tumor size. So if you have a larger tumor volume, that tends to lead to poorer hearing outcomes. But then the other thing that affects it is actually the growth rate. So the tumors that are growing faster are actually going to be are going to have worsening hearing over time. So this is just looking at tumors that are growing less than 50% and then greater than the 50th percentile. And looking at grade A hearing and then just serviceable hearing. So either for grade A or serviceable hearing, those tumors that are growing faster are having worsening hearing outcomes. So that's an important thing, right? Because we think about, if the recommendation really is to observe these at first, is that a good recommendation to make, given that we know that if these people are just being observed and their volume is big to begin with, and their volumetric growth rate is faster, then we have now data to show that perhaps that their hearing outcomes are going to be worse. So that perhaps we should be rethinking or at least considering earlier treatment, or, I'm not sure that the data has gotten us there yet, but it certainly is trending towards that direction, which is, vastly different than it had been previously. This is another data this is another paper out of the Kano group, and it came out in Journal Neuro-Oncology. And I think this is another one that's good. So the good thing about all these papers, if you can look at it, we're really not just looking at things in isolation. We're really starting to look at hearing and serviceable hearing, grade A hearing, and patients with and specific, like a pure tone average and speech discrimination scores. And what they're showing here is that essentially patients who are going to undergo stereotactic radiosurgery before their hearing declines, so when their hearing is still either grade A or still very good hearing, and either way, certainly before serviceable hearing, that those patients tend to do better in terms of their long-term hearing preservation. Okay. So I think the data really is starting to support earlier treatment. So when patients come to the office, they want to know what the decision tree is like, so you're talking to them and you tell them, okay, these are your options, you can observe it. And we just talked about what that looks like, what observation looks like. We now have data that's actually looking at patients who were observed, and not only at patients who were observed, and we can tell them, yes, those tended to grow, but we also can tell them what happened to the hearing. And that's all you can really do, is give the patients the information. So now they have the information about the patients who were observed, whether or not they grew, and now the patients who were observed, whether or not their hearing preservation rates were lower. And the truth is that if they had a higher volume to begin with, or they showed a faster growth rate, that observation tended to lead to poorer hearing. So we have that. And then, you have your treatment options, which is going to be your gamma knife radiosurgery and surgical resection. I'm not going to focus on surgical resection today, although that's obviously critical. And I think there's in high volume skull-based centers like we are, we have a certain bias for surgical resection. And I think that the determination of whether or not your institution has a bias for surgical resection has to do with outcomes, right, and experience. So if you're in a place that doesn't have a high volume of vestibular schwannomas, you're going to be biased against resection because some of the outcomes can be very poor. But if you're in a place that does it at a high level like we do here, I think that surgical resection is safe in the right hands and can be done very well. So I think we have a slight bias to that here. But today we're really going to focus here in the middle portion of this decision making chart. So it turns out that we're not the only ones who thought about this. Everybody's been thinking about this for a long time. So this is again another paper out of France looking at this wait and see strategy as opposed to treatment strategy, right? So here in their study, so they defined rate of failure as in rate of failure of observation. So the need for either SRS or microsurgery in the presence, and that was usually due to either tumor growth or hearing decline. So the rate of failure was higher in the wait and see group, right? So that makes sense. And most importantly, tumor control and preservation of functional hearing was better in the proactive gamma knife group in the first 5 years. So this is, this is again showing some of the data of where people started to think, okay, well, perhaps we should be being more proactive about this. And the papers that advocated not being proactive, like the one I showed you before, had some major flaws, which is, they were not looking at the right things. They weren't looking at the cochlear dose, and cochlear dose isn't everything, but it is important here. So, this is okay. So then the other thing that patients come to us and ask us is tinnitus, right? So a lot of these patients end up getting MRIs, and they get MRIs because they have severe tinnitus, and that's very bothersome. And they'll get an MRI and they'll find an acoustic neuroma. And so then we know how do we fare in terms of tinnitus? And I actually think this is an area where some of our research efforts should be really focused on this, because it severely impacts people's quality of life, and we're not really good at addressing it. We're not, the etiology of it and sort of the pathophysiology of it is complicated, and we're not fantastic at treating it. And what this paper shows is that either treatment, regardless of whether it was SRS or open surgery, fared better in terms of addressing tinnitus than observation alone. So patients who were just observed tended to have more debilitating and persistent tinnitus, whereas patients who got treatment, and that treatment was either surgery or SRS. And you can see here that regardless of the approach, either translab, retrosig, or modal fossa, were all the same in terms of SRS. So regardless of approach, treatment was better than no treatment in terms of addressing people's tinnitus. Cost effectiveness, that's another important thing from a hospital standpoint. And, this paper looked at that. And for many reasons, we really have data to show that radiosurgery ends up being more cost effective. And a lot of this has to do with the complications that can come from acoustic neuroma surgery. And essentially, once you throw spinal fluid leak in there and readmission for spinal fluid leak and return to the OR for spinal fluid leak, radiosurgery ends up being more cost effective than surgery. And it ends up being, more cost effective than observation alone. And if you take into consideration things like the number of MRIs that people are going to continue getting, and the other thing that observation is not great, that doesn't lead to good outcomes, is if you have patients with really disabling vestibular symptoms. They actually are having a lot of ER visits due to their symptoms, and that in and of itself leads to observation being less cost effective than treatment. So, there was some data here from 2004 to 2007 showing that there's a decrease in surgery, and then in sort of a little bit of an increase, not significant, in observation, but that radiosurgery really went up here in these few years. And I think, I'm not sure that this data is fully complete, or I think it really just gives you a small moment in time. But I think the important trend here is that there are some severe outcomes from, having a complete facial palsy and, CSF leak, whatever I'll say, maybe there can be significant consequences from surgery if you go for complete resection of every single tumor. And so there was, and almost like everything, there was this, shift in the pendulum from being as aggressive as possible and getting a lot of house 6 facial palsies, house 5 and 6 facial palsies, to perhaps we can debulk the majority of the tumor and do this sort of adaptive thing where you take out most of the tumor, and if it's really stuck on the facial nerve, you leave a little bit behind because you have radiosurgery available to you, and you have very good outcomes with that. Now, that's tricky, and that is, I think most of us would agree, who are focused on skull base would agree that there's a fine line between that approach, which should be great. The shift from gross total to a more balanced approach is a positive thing, but I don't think it means that you can go to every tumor saying, I'm going to leave a little bit behind. I think most of us skull-based surgeons go in with the goal of having a complete resection. And this is just almost like a bailout. If it's not possible, or if it's not safe, then yes, maximal safe resection, with the knowledge that you can always gamma knife a growing residual. So that's always in the back of our head. So this is again just showing that, looking at the facial nerve outcomes really started to become more of an impactful concept to us, and we really started to study that. So when we talk about acoustic radiosurgery for acoustic neuroma, we have to keep our goals in mind, and I go through each one of these with my patients. We want the tumor growth. We want to control tumor growth, right? This tumor has to stop growing. Ideally, and it's interesting, patients don't like, if you tell them your tumor is stable, they don't like that. They really want tumor to regress, and that happens, but it's not always. Sometimes, I always tell them the goal of radiosurgery is to stop the tumor from growing. Having said that, tumors will, 70% of the time we do see tumor regression, but it's important for them to know. The other consideration is that you have to look at surgical risks in each particular patient, and eliminate those risks, and radiosurgery does that. The other thing that's important is maintenance of cranial nerve function, particularly facial nerve function, and then obviously hearing. Patients want to know about their hearing, and then improve patient symptoms. So if the patients already come with symptoms, like I said, tinnitus and vestibular symptoms, radiosurgery is somewhat limited in improving those symptoms. So keep that in mind. So our radiosurgery devices that we can use include, these are all radiosurgery techniques, either with the gamma knife or with the Linac. You can do cyberknife based. We have the gamma knife here. And then, there's also some literature there that talks about fractionation. And I'll probably mention that at the end, although, I don't think that's the best approach for acoustics. So this is the ideal result, right? You have this small right-sided intracanalicular acoustic. This is at the time of radiosurgery on the left. You can see here at 6 months that you have this central necrosis in the middle. It becomes darker as expected. Look at that. At 8 months post-radiosurgery, you can barely see it. And then, you've maintained very good hearing. Your hearing remains good. And then, interestingly, if you look at the T2, and I'll go over this a little bit more, you have bright cochlear signal, regressed tumor, normal hearing. This is your perfect outcome, ideal result. This is what we're all looking for. We don't always get it. And the other critical thing about this is nowadays people are coming to you even earlier, right? So people are coming because they're being diagnosed earlier. They're getting MRIs for headaches, they're getting MRIs for tinnitus and other reasons. They're really coming to you and they want this perfect result, which is not always possible to give. So how can we, so in terms of cranial nerve preservation, most importantly, and it turns out, and I'll go over this at the end, that hearing is not the most important things for when it comes to patient outcomes. But the first thing people want to tell you is, am I going to keep my hearing? Because this is what they read about, right? And so then we have a lot of papers that looked at how do we do this? And the best way to retain class 1 hearing is really with early radiosurgery. So why is that? Because if you can do radiosurgery when you still have very good hearing to begin with, then your outcomes and your chances of retaining hearing are much higher. So here's another paper showing the same thing, which is that these are all class 1A, 1B, very good hearing to begin with. If you have better hearing, your hearing preservation is better. So if you start with good hearing, you're going to end up with good hearing for a longer period of times. And even with these are, these subclasses, these are all subclasses of excellent hearing. So you're still going to keep better hearing the better hearing you start with. So that's an important concept. How, what we looked at this paper. We looked at this concept at NYU as well, because we were trying to figure out what is it about the hearing? Like I mentioned before, is it direct compression? Is it a vascular phenomenon, or is there a protein issue? So if you look at this, this is a KISS sequence or a Fiesta sequence on an MRI. It's a T2 weighted sequence where you can see the cranial nerves very beautifully going into the IAC here. And if you this is the cochlea here on this patient's right side. And if you can see the cochlea compared, this is very bright, hyper intense here. And then if you look at it on the side of the vestibular schwannoma, you have this sort of grayish appearance. So we looked at that, and we actually saw that cochlear T2 signal, or maintenance of the cochlear T2 signal, T2 bright signal, actually was associated with better hearing function. So in patients, if you look at this patient on the right here, they have an acoustic here and a bright cochlear signal, and then they actually preserve their hearing after radiosurgery. Whereas this patient here, this is the acoustic, and you can see that their cochlear signal is actually dark here, and they lost their hearing post radiosurgery. So is it something that is there some sort of protein accumulation that causes worsening hearing after treatment that you can tell from the preoperative T2 cochlear signal? So that was sort of an interesting finding. So how does radiation work? So essentially you're causing DNA damage, right? So radiation injury, it causes an inflammatory reflect, and ultimately you want that inflammatory effect, and chronic inflammation is going to end up scarring, and then scars are going to contract. So that is ultimately what we cause, but we do cause this biological change in the tumor that leads to radiation injury. And that ultimately causes to this inflammatory effect that can cause the tumor to shrink over time. So if you look at here this is just a couple examples for you at the time of Gamma knife on the left, 4 years post Gamma knife, and then you can see here at 10 years shrinkage. Okay. Another example of that. At the time of Gamma knife, 6 months post Gamma knife, you can see the central necrosis again, and then 9 years later, you have shrinkage. Okay, this is 14 grays, a dose that this is an older slide from Doug, and this is higher than the dose that we use now. You'll see more examples of this, 22 years later, 17 years later, 19 years later, and 20 years later. So one thing, this slide is really just important to highlight. Patients will come to you and they want to know, is this going to look, is my MRI going to look better? Is it going to shrink? They don't want to hear my tumor is stable. They want to hear, is it going to shrink? And I think there's plenty of data to suggest that a lot of these tumors will in fact shrink. Okay. However, it is important to guide all of these patients that there can be a small amount of temporary expansion as the tumor responds. So we just talked about this, that we cause this biologic effect that leads to an inflammatory response, and inflammation can swell, right? So you can see here, this 29-year-old with hearing loss, this is at the time of radiosurgery. You can see here at 2 years, okay? And so here's the question is, what would people do? A lot of places, if they saw this image at 2 years, would say, well, this is growth, this is progression, and we're going to take this out or retreat. Is that necessary? Well, sometimes, perhaps. I think you have to look at the patient, right? You can't just look at the images. What are the symptoms like? Is this just a complete radiographic response, or is it a clinical response? Is the patient getting more symptomatic? Are they getting dizzier? Are they getting worsening hearing? So you really have to sort of take that into consideration as well. But you can see that there's this expansion at 2 years, and then at 17 years, this shrank. So this is an example of expansion and then shrinkage. Here is a dramatic example of that. This is out of Hong Kong. So this is a large tumor, and I don't quite remember in the paper why it was. I think this patient was just a very poor surgical candidate and therefore couldn't have surgery. So radiosurgery was done. This is at the time of radiosurgery on the left. You can see here, on B, you have that central necrosis that I talked about, which is showing a treatment effect, right? And the size is still the same at this point. Here in C, 24 months after treatment, so 2 years after treatment, you have this expansion, which I think most of us would probably be very nervous to see this and not do something about it, right? This is why, again, you have to realize that this is, a select case here, and this is why it's being reported, right? It's a case report. So this patient, I guess, in the paper, they happen to be perfectly fine, completely symptomatic. I think in the majority of skull-based centers, this patient would have gotten a resection, but they didn't, and the patient was clinically fine at the time, and so they continued to observe it, and here they are, along of 225 months after treatment with dramatic shrinkage of that tumor. Again, every exception to the rule, right? I'm not saying that every patient's going to be like this. I think most patients would likely have symptoms, and your hand would be pressed to do something at this point, but it's showing this a dramatic example of what I said, that these tumors can really grow before they shrink. So this is sort of the evolution of the gamma knife technique for the radiosurgery technique for acoustics. So first, in 1987 was when, you saw some of those examples that I was showing you from Doug. Those are very old examples, and you can see that they were sort of using the CT for planning, really use of MRI in 87. Then you saw some of those doses that were 14 grays. That's really greater than what we use. Most of us stick to 12 to 12.5 gray for the margin dose. That was 92. 2004, the cochlear dose became a thing, and that became a thing because the ENTs actually started to go to the course, and they started to talk about the cochlea, and this was not necessarily a thing that neurosurgeons really talked about, but all of a sudden they're talking about cochlear dose, and that started being measured. 2008, we really realized this concept that keeping the cochlear dose low was important for long-term hearing preservation outcomes. And then, this continues to evolve. In 5, we have new dose planning software concepts as well, and different additions to the machine. So again, talking about the cochlea came about when the ENTs came to the course, and they really started to show us, hey, this cochlear dose thing, we might be onto something, right? But initially, we wouldn't really think about cochlear dose, and we would treat this without measuring the cochlear dose. And we kind of just would occasionally get lucky, but that's sort of not good enough. So we started to measure cochlear dose over time. So this is, again, an example of a patient that was treated at the time of gamma knife, and this is at 3 years. If you look at that, at the, this is the initial audiogram, and you can see this person has maintained really good hearing. Again, there are patients, this is not every single case, but this is why, each patient needs to understand that the data goes both directions in this. There are patients with large tumors who maintain very good hearing, such as this one, and there are patients with, like that small one that I showed, with a minimal amount of growth, perhaps a bigger volumetric growth, that they lost their hearing completely. So it's an important conversation to have. And these are just examples of patients, who've maintained good hearing. These are sort of our success stories, right? So a lot of, and you have to think about that. And some of these, the reason, let me actually just go back a few here. One of the things that you think about with why do these people maintain it? Again, we don't know what is causing the hearing loss, but you got to think about whether the shape of the tumor has something to do with that, and whether you're able to shape your radiation dose away from the cochlea. Again, this is a tumor that's extending pretty far out into the IAC. So, you wouldn't necessarily expect such a great hearing outcome, but you can get it sometimes. And there's different techniques. And I think I show you in another case where you try to actually use a blocking, one of the shots that blocks the radiation away from the cochlea so that you can preserve this good hearing. So then, so what about cystic tumors, right? So people traditionally say, oh, cystic tumors you shouldn't use SRS for cystic tumors. It doesn't work. Or they have this concept of, oh, perhaps you should do surgery to decompress the cyst and then do SRS. And then, then there's the counter argument to that is once you've done the decompression of the cyst, by the time the patient's wound is healed and you're ready to give them radiosurgery, a lot of times the cysts can come back. So that becomes problematic. But here's an example of a cystic tumor with very good hearing. And you can see here, the tumor underwent radiosurgery. That same tumor, the cystic component is almost gone. You can see there's still some enhancement here, and the speech discrimination score is still 96%. So very good hearing. So this is an example of a cystic tumor that responded very nicely. And in fact, cystic tumors do respond really nicely. And I think there's a common misconception that they don't. And I think it's important that people know this, because cystic tumors, essentially the tumor is just representing a degeneration. And so the radiosurgery, the biologic effect that it has on these cystic tumors, it's almost like the tumor is doing some of the work for you. And so the radiosurgery tends to work pretty good for cystic tumors. And that's important to keep in mind too. It's already degenerating on its own. Here's another example, 87 years old. I think everybody would agree that perhaps that's not the patient that you would go and do a big open surgery for. Facial numbness and partial facial weakness, which again, you have to take into consideration, patients with facial weakness. This is a large enough tumor that could cause a facial weakness, but you always want to consider a facial schwannoma instead of an acoustic schwannoma. Regardless, this is a large tumor, has a cystic component, 87 years old, so underwent SRS at 11.5 grays. And so you can see here at the time of SRS, you can see here some degeneration of the cyst, and you can see here the cyst sort of just falls apart at 14 months. You really have decompression of the brainstem and shrinkage of the tumor. So this is an example of a good outcome in a cystic tumor. Okay, another example, 83 years old, internal cystic changes. We see this a lot. These cystic changes are concerning, right? Because I think a lot of people are hesitant to give a radiation, and they're concerned about not fractionating the radiation. I think a lot of the radiation oncology team members also have concerns about radiating something like this. They start talking about, we should shunt this patient. Is that a problem? Should we do the shunt up front? Well, some of these patients, this patient just underwent radiosurgery, single session. This is at 2 months. Okay. And then look at this, 2 years. The internal cystic changes really sort of involute, and there's tumor shrinkage away from the brainstem, a lot less compression. The patient did not get a shunt. This is not to say that this is every single case, but I think there's a common misconception about cystic tumors that we really have to rethink. So what are the predictors of hearing preservation after SRS? Well, we talked about some of this already. but we talked about the cochlea being important, right? So it's one of the papers, this particular paper looked at it, and a lot of the papers that have come out since have sort of chosen 4.2 grays as the maximum cochlear dose, anything above which you can get worsening hearing outcomes with. So cochlear dose becomes important. Age, patients who are younger tended to do better. Patients who are older tended to have worse hearing outcomes. This is cochlear dose. Again, a lower cochlear dose, they tend to keep their hearing for, this is hearing preservations at 1 year and 2 years. So people with a lower cochlear dose, and you can measure that, tended to do better. And then patients with intracanalicular tumors as opposed to extracanalicular tumors tended to do better. And this, there's this concept about whether or not the tumor begins to grow once it goes into this, from the IAC into the CP angle. So once it becomes extracanalicular, these tumors tend to have, or there's a concept of that they tend to have a faster growth rate. And so I think this can possibly be explained by that volumetric growth rate study done from NYU. If it's saying that hearing preservation is associated with growth rates, then it sort of goes in play with why the intracanalicular tumors tend to fare better in terms of their hearing. So cochlear dose, again, isn't everything. And I think I'll show you some slides about how and why we've started to think that. But it is something to take into consideration, right? So here's an example of a tumor that doesn't completely fill the fundus, larger volume. At 2.5 years, speech discrimination score is 96%. So the big question, and I know this comes up a lot, is how long is this going to be for? Is it going to be maintained? At 5 or 10 years, the data says that patients should have some hearing loss. And I think that's the truth, is that long term, you're going to have you're going to have some hearing decline. So when you're looking at a lot of these papers, when they're telling you that they have good hearing preservation, oftentimes it's at 1, 2, 3 years. And what we're wondering is what's going to happen at 5, 10, 15, 20 years. And there's going to be some decline. It can be sooner or later, it can happen. And so you see here, this is an example of a patient that underwent radiosurgery, started out with pretty good hearing. This is at 6 months after the Gamma knife. You don't really see much change in the audiogram, but you can see here at 29 months after the Gamma knife, there's a decline. So, that hearing decline is going to happen at some point. And I think a lot of our data is sort of their early studies, and they don't have some of this later long-term data in there. So for the interest of time, this is a similar paper looking at some of the same things in terms of hearing preservation. Age matters, cochlear dose matters. Less than 2 and less than 3 grays tend to have better outcomes, although 4.2 is sort of like the upper limit. And this is what I mean by cochlear dose is not everything. So this is looking at speech discrimination score follow-up versus mean cochlear dose. So this is the mean cochlear dose from 0 to 6, and then speech discrimination score is on the y-axis. And these are for patients with good hearing to begin with. And if you look at patients with really excellent hearing, you can see that cochlear dose isn't everything. You have dots sort of all over the place here in terms of patients who are getting higher cochlear dose and have better or worse speech discrimination score. So I think the fact that there's almost a fairly normal distribution here shows that cochlear dose really can't be the whole story. And again, I think and this is the same sort of graph, but looking at worsening or speech discrimination score starting at 50 to 90 as opposed to 90 to 100, which was the excellent one that we started with. And again, I think things that we're not taking into consideration if you just look at cochlear dose is the length of time that the tumor was there, right? How perhaps it's been there for a long time. The protein content, we looked at the T2 signal, that matters. Vascular, so there are a lot of different things that we have to take into consideration that if you just look at cochlear dose alone is not enough. All right, so the other things people care about, facial nerve function. Well, you can't really do much better than Gamma Knife. And this is what I, sometimes at M&M we'll talk about this. The rate of facial weakness after Gamma Knife is really just 1%. So that's excellent. And people want to hear that. And I think you can't really get better than that with surgery. Even if you're, a master surgeon like we have here, you're still going to have a higher rate than 1%. Okay. And people care about their face, it turns out. I'm going to skip over some of these. This is just really to show you that some of those shapes. I think one important thing is that, to be able to get to sort of push the cochlear, the dose away from the cochlea, you do have to use some techniques like blocking. And again, keeping, using a low dose like 12 or 12.5 grays. So long-term complications after radiosurgery, you can see here, they're pretty low, right? So you can have some hydrocephalus, you can have some trigeminal neuralgia, but overall, decent complication rates, particularly when compared to surgery. So I will skip this because I do want to get to some of the stuff at the end. So what about age? I think one of the big biases here at our institution is that, if they're young, they should really get surgery. So then how do young people fare with radiosurgery? Well, and that's one of the critiques too, right? They're saying this person's young, it has to last for a long time. So do we have enough long-term data? Well, we have some longer term data. This is not perfect. It's looking at 10 years. It's not looking at 20 years, right? We're not looking at 20, 30-year data, but it is looking at 3, 5, and 10 years. So that's pretty good data, or at least pretty good length of time for follow-up. And it, like everything else, patients who are younger tend to fare better, right? So I think certainly, if a young person comes to your office, you can't tell them that you have extensive data past 10 years, but you have some longer term data, and patients tend to do well. So, in the absence of randomized trials, because you're not going to be able to randomize a trial like this, there's I like this matched cohort study from NYU. This is looking for smaller and medium-sized tumor. This is often a source of contention or a source of disagreement. So this is tumors less than 2.5 centimeters, right? I think overall, the bias has shifted such that intracanalicular tumors, most of them are getting radiosurgery, and the very large tumors with brainstem compression where patients are symptomatic, patients are getting surgery. What about these the smaller and medium-sized tumors? What do you do, right? And so I think this is a matched cohort study, and looking at some important things, looking at both. It looked at all the different approaches, retrosig, translab, and middle fossa, and then, sort of did a matched cohort compared to radiosurgery. So both intervention-free survival as well as tumor control rate, very similar. Both SRS and surgery does very well in terms of getting to the goal of getting the tumor out. In terms of facial nerve preservation, again, you can't really get much better than SRS. So for facial nerve preservation, SRS tends to do better, but it's important to note that you have excellent outcomes still with surgical resection. So that, you have to remember that even though radiosurgery is always going to be better, you still have very, very good outcomes with surgical resection. And then in terms of hearing, when you look at the matched cohort, hearing is better with radiosurgery in the early years. But if you look at the 5 year, at about 5 years, these survival curves tend to converge. So again, I think we can say that the really good hearing outcomes in radiosurgery can be offered initially, but eventually it does converge, which just means it's not durable, right? So when you're looking at 5, 10, 20-year data for that, it's going to not be as good as surgery, right? Because if you can preserve surgery preserve hearing with your surgery, you're going to maintain that forever. So the degree of complication is going to be, specific for each approach. Obviously, the surgery is going to have things like CSF leak be much higher. You really are, where SRS is obviously going to be here 0. So these just, it goes over some of the surgical risk factors, right? And then, so bottom line, when you look at this, Gamma Knife and surgery are going to offer similar intervention-free survival rate. Gamma Knife does provide good imaging tumor control, as well as better preservation of cranial nerve 7. It provides better hearing preservation during the first 5 years postoperatively, but it's not durable. So the curve, those curves do converge. And then, if you're looking sort of for comparison studies similar to this one, I would urge you to look at some of these studies, and it goes sort of in a similar fashion, comparing one thing to another. A few notes about what the upper limit of size. Can you do radiosurgery for large tumors? The answer is yes. You can do that. You're going to have, you're going to have some issues because of that transient swelling, but it is possible to do, and you can have some very good outcomes. And here's an example of that, right? So these are Coues grade 4, so large vestibular schwannomas. Most of these patients are chosen for a particular reason, right? These tend to be patients that are not good surgical candidates for one reason or another. And you can see here that this patient got radiosurgery and had very good radiographic response. And then, you really have to look at each patient separately to see whether or not, if they have that swelling period, that they need to be treated you have to intervene at some point. And again, oftentimes this takes a long time. So you have to be very patient with your imaging. Okay, these are, again, some of these studies that show examples of this, right? So finally, I want to get through to this part, which is the quality of life after radiosurgery. So I have to say the Mayo Clinic did a fantastic job with some of this, and they worked with the ANA, which is sort of the patient group, to ask what matters to the patients, right? And so they did this quality of life, this PanQual study. And it turns out that when they talked to the ANA, they talked to the patients and they asked, what matters to you? Number one is that the tumor stops growing. So stopping the tumor and having good growth rates is important. Number two, preservation of facial function. Okay, it turns out that if you have a complete facial palsy, that can be very debilitating. Number three, preservation of balance. Okay, balance is a very debilitating factor. Again, remember that I said that this leads to a lot of ER visits, which is why it becomes it becomes an issue with cost. And finally, number four is hearing. So hearing is actually on the low end of that spectrum, which I don't think people realize, because when they come to see you in the office, the first thing they ask about is, am I going to keep my hearing? But then it turns out that patients who had hearing loss due to acoustic neuroma because of either surgery, just because of the natural history, and or because of radiosurgery, they say they get used to that, and it's not a big impairment in their quality of life. Again, another paper looking at that vertical imbalance, and then hearing loss has the greatest impact on quality of life. So, so another concept that people ask about, what if radiosurgery fails? Is resection actually more difficult after radiosurgery? I think we've we've all had cases where patients have been radiated and you go in there and things are very stuck. It's very sticky, very fibrous. And then you have cases where you go there and there's a relatively good plane along the facial nerve despite having had previous radiation. So there's, this is a small sample, obviously 19 only resections here. But the interesting thing about this is that in terms of the surgeon's opinion, most surgeons said that the surgery itself was more difficult, but in terms of facial nerve outcomes, there was no significant difference. Okay. What happens if the tumor still grows after it's been radiated, which is a small number of cases? Really, you have a 97 to 98% control rate with radiosurgery. Can you have it again? The answer is yes. And there are studies to show that, in fact, that the response to second radiosurgery is pretty good. So you have that option in the back of your pocket. Then just a few words on fractionated radiotherapy. Again, I don't think that this is the best sort of approach for acoustic neuromas. But the concept of this was, can we give the cochlea or the nerves time to recover prior to giving, that's the whole concept, is you want to give it time to recover, and perhaps that leads to better outcomes. But this really didn't pan out. And this is just some of the studies looking at fractionation. So I think the important thing for acoustic neuromas and radiosurgery is accurate radiation delivery. You want it to be conformal, and you want to have a very effective intratumoral response. And you want to have a low, because these are benign tumors, keeping the margin dose low. 12 and a half grays is going to allow for good outcomes in terms of tumor control and keeping cranial nerve morbidity low and also cochlear dose low, which tends to lead to better hearing preservation outcomes. Who should not have radiosurgery, right? If the patient comes to you and says, I want this out of me, that's an option. And I think this is a misconception, is that, you shouldn't even offer. And it's, I think Dr. Heroes makes a good point that we shouldn't do things for the patient that we don't believe in. However, we have to understand that the data really does show some equipoise in terms of a lot of this. So it is controversial, and it's a delicate conversation to have with patients. And I do think you can definitely guide them in a certain direction and show them what the data shows and shows this and show this equipoise and show these controversies. But ultimately, you have to remember that this is an area of quite significant controversy. So these conversations can be complex. If they have major imbalance from brainstem compression, intractable headaches, trigeminal neuralgia, hydrocephalus, or, if you're considering some other alternate diagnosis. And the one really last statement is that we did with the risk of malignancy. Some people will come to you and they say, well, if I have radiosurgery for my acoustic, am I more likely to develop cancer? And the answer is no. Patients who get radiosurgery are at an equal risk as the general population to getting a malignancy, and that's in about 1 in 5,000 to 6,000. So in summary, radiosurgery should be performed by experienced teams. We should be using dedicated high quality radiosurgical device with very high resolution imaging. You got to pay attention to the cochlear dose for hearing preservation, although that's not the whole picture. And, you have to always have a commitment to evaluating your own results, both radiosurgical and surgical, in order to continually improve patient outcomes. That's all I got. Any questions?
Dr. Benjamin, can you hear me?
Hey, Brad, how are you?
Good morning. Yeah.
Good morning.
Yeah, I hopped on late because we had our own grand rounds residents presenting their research presentations, but I did catch the tail end of what seems to be an excellent talk. You did address some of the issues that are of particular importance that we see, hearing loss and also the vestibular. And we have pretty good, as you know, ways to mitigate those issues of single-sided deafness, even when there's no cochlear nerve, with rerouting of sound with hearing aids and bone conduction implants, things like that, as well as gentamicin and other ways to mitigate the vestibulopathy that may occur from these. I didn't hear the first part of your talk where perhaps you discussed the issue of radiation for obviously growing, but non-growing. We see a lot of patients come from other institutions who've been radiated when, based on only one MRI scan.
Yeah, so I did bring that up. And again, I think there are papers going in both directions. I brought up a paper that talked about the fact that it was a pretty clear paper, and in their conclusion, they said that this should not be done. And I think there's a series of papers that are out there that say that. A couple of things. One thing that I do think is shifting. I showed a natural history paper that came out of NYU and out of the Mayo Clinic, showing that actually about 66% of vestibular schwannomas tend to grow. So I think we're going to get to a point where perhaps we'll be able to say, hey, if you have an acoustic neuroma, perhaps we should treat it sooner rather than later. I don't think we're there yet in terms of the data, right? These are small, 2 series from 2, high volume centers, but not really extensive yet. The interesting thing, there's a paper in Journal of Neuro-Oncology from Reno that I think actually is a good paper, because it does say that for those tumors that were observed, their hearing outcomes when they got radiosurgery tended to be worse. So I think our data eventually is going to lead us to believe that perhaps we should be treating them sooner, but I don't think we're there yet. I think we're just starting to demonstrate that these in fact grow in a more significant fashion than we anticipated, and that perhaps once we've waited and watched, that we've lost something. Because even if you have a small decline in hearing, that small decline may be enough to lead to a worse outcome in terms of long-term hearing preservation.
Thank you.
Thank you very much.
Okay, thank you, Dr. Benjamin, for an outstanding talk. If there are no other questions, we're now going to move over, continue discussion on spinal cord injury. And today I'd like to introduce Dr. Jay Lee. Dr. Lee is a professor in the Department of Neurological Surgery and an important member of the Mind Project to Cure Paralysis. Dr. Lee and colleagues over the years have been looking at the inflammatory responses to CNS injury. And as we know, there's certainly helpful inflammatory responses as well as inflammatory responses that are degrade the tissue after injury. So Dr. Lee and colleagues have been looking at big data and informatics. And today we're going to talk about some of the informatics approaches to targeting macrophage activation after spinal cord injury. Jay, thanks for joining us this morning.
Thanks, Solomon, for the kind introduction, and thank you for coming this morning. I'll share my screen and we can get started. As the title indicates, I'm going to kind of give you guys some overview of some of the projects that are going on in my lab right now. I'm using bioinformatics to kind of try to solve this puzzle of how to target macrophages at the spinal cord injury site. I've probably, when I first came here 12 years ago, I never would have imagined that the word bioinformatics would be the title of my presentation, but so it comes as a surprise to me as well. But I'll kind of show you how the work has evolved over the years and the influence of really some key collaborators at the Miami Project and other institutions that have really allowed me to pursue this avenue. First, I'm going to start with the people by thanking the people that have actually done this work. So here's a picture of my lab post-COVID. Some of the work that the work that I'm going to be showing you today is primarily by three talented scientists. One's a recent graduate student who received her PhD, is now starting med school at UM, Christine Ryan. Let me put my laser pointer, Christine here. And then also Susanna, who's an assistant scientist in the lab, is also spearheading a couple of projects that are related to the talk today. So these two have a lot to thank for. And then Lindsay, who has graduated, Lindsay Milish, and then James Choi, who's back here, is kind of our chief bioinformatician at the Miami Project, who's contributed a lot to this work. And then obviously my collaborators. So the Lembix lab, and then Hassan Ali has been really instrumental in getting our high content screening assay up and running. And then Carlos has been nice enough to show us how to use this seahorse assay. And Nagiaya, who many of you know, was here until recently, is now at Georgetown, has also been an important collaborator and colleague in some of the projects that I'm about to show you. So my lab studies the wound healing response after spinal cord injury. And really, you know, we don't use the term wound healing response, at least from a basic science level, in referring to the central nervous system a lot. But if you think about the sequelae of events that occur after spinal cord injury, or actually even after any traumatic injury to the central nervous system, they're the kind of the hallmark steps to what typically we consider as a wound healing response. So first, we start with inflammation, right? And that starts immediately after injury. We have a lot of tissue debris. And you know, we have a infiltration of a lot of immune cells that add to the heterogeneity of this injury site. And this heterogeneity is something that has been in the back of my mind for a long time. And this is something that we're trying to tackle using bioinformatics, as I'll show you a little bit later. And then this phase of acute inflammation is followed by cell proliferation to replace lost cells, mostly glia and leukocytes, obviously neurons, and neurons don't regenerate here. And then this phase of cell proliferation is followed by a tissue remodeling phase that occurs over a long period of time, starting weeks to years. And then in the end, eventually, this tissue remodeling process gives rise to two types of quote unquote scars that we commonly refer to. So the injury center, this lesion site, is often what we refer to as a fibrotic scar. And it's very similar to a fibrotic scar that you would think of in the context of skin or liver. And then this glial scar that most neuroscientists are familiar with. And there's in fact, this separation of these two regions that occur often. And these two scars are kind of what we typically attribute as the end result of a long and complicated wound healing response. A lot of this response is driven by infiltrating monocyte-derived macrophages. And so we and many others have shown this over many years. And so to kind of get our foot in the door about how macrophages are mediating the scarring process, several years ago, a talented postdoc and graduate student, Yin Zhao and Kiro, kind of took on this really, at the time, very technically challenging project. So at the time, a lot of the transcriptomics based on microarrays and RNA sequencing were based on bulk tissue. So you would, grab a piece of the injury site from the spinal cord, and then you would get total RNA from there and perform RNA sequencing. And that's obviously been very important and has led to a lot of important insight. But it fails to kind of convey the complexity of the cellular heterogeneity that's present at the injury site. So it's like basically, taking a fruit salad and then throwing it in a blender and getting a fruit smoothie, right? And so because of our interest in macrophages, we took this approach called a ribotag, where we have this transgenic mice in which the polyribosomal protein is tagged with hemagglutinin. And you can get this tagging based on a cell type specific Cre line. In this case, we used lysam Cre to target myeloid cells. And so the myeloid cells, as you can see in red here, are going to have polyribosomes that are tagged with hemagglutinin. And then you can homogenize the tissue and perform immunoprecipitation to pull down the polyribosome, and then do RNA isolation to get the mRNA that are associated with the polyribosomes that are in myeloid cells. So we took this approach, did the RNA sequencing. This was kind of our first foray into RNA sequencing. We got a lot of help from the Lembix lab, especially Matt Danzy when he was a graduate student in the Lembix lab. And we were comparing 2 time points, 3 days, which is when kind of macrophages start to appear. So it's still mostly monocytes at that stage. And then we compared those macrophages to macrophages at 7 days, which represents kind of the peak of macrophage infiltration after spinal cord injury. Remember, there's really there are no monocyte-derived macrophages in the uninjured spinal cord, so we couldn't use an uninjured spinal cord for this purpose. So we had to kind of pick and choose our time points here. And so when we compare the differentially expressed genes between these 2 time points, we were surprised to find pathways that were related to lipid catabolism. So these were the top gene ontology biological processes that were revealed by the data set. And in the beginning, we were, kind of expecting or hoping to find mechanisms related to inflammation, cytokines, something that might drive the scarring process. And so when we got these results back, we were a little bit puzzled, scratching our heads, not knowing really what to do. And so what we decided to do then was we said, okay, let's compare this transcriptomic data set with transcriptomic data sets from other macrophages that have been described in many other contexts. So obviously, macrophages are probably one of the most widely studied cell type across all disease models. And so there were a lot of publicly available data sets on macrophages. So some from Arrivo, a lot from in vitro, treated with various pro-inflammatory or anti-inflammatory perturbagens. And so what we did was we took this gene set enrichment analysis. Basically, you're comparing your differentially expressed genes to those of many other data sets, and then it ranks it based on, and so the highest ranking score, as you see on top here, indicates that this particular cell type, this data set, was the most similar to our data set. And consistent with the discovery of lipid-associated genes, this foam cell phenotype seemed to be the most similar to the macrophages that were present at 7 days after spinal cord injury. And so again, foam cells is something that are very familiar to clinicians, but to neuroscientists, it's still something of a mystery and something that term that's not often used. And so, when we looked up foam cells in spinal cord injury, there were a few papers. And so we confirmed this using our own injured mouse spinal cord tissue. So this is sagittal section of a mouse spinal cord at 7 days after injury in red, and these oil red O staining that stains for neutral lipids. They can see these large red circles over here. And then CD11B labels macrophages. And so you can see this huge accumulation of macrophages that become filled with huge lipid droplets by 7 days after injury. 3 days, they start to appear. Obviously, we have macrophages, but then they're really not filled with these large lipid droplets over time. So this was kind of confirmation of the transcriptomics data and the bioinformatic analysis that led us to the stage. And this has been really kind of and so we decided to kind of, go where the data took us. And it's been really fruitful over the last 7 years or so. We've gotten several grant applications on this, along with really key collaborations that have led to some really interesting results, as I'll show you. Now, this foam cell phenotype is present in human spinal cord injury pathology. In fact, this is one of the few spinal cord injury pathology that was first described in human tissue as opposed to rodent models. So you can see here, and so a lot of that actually came from work from the Miami project. This is a paper from Dr. Michael Norberg's lab when he assessed the library of human spinal cord tissue that we have. And you can see that these large kind of empty vacuoles is seen in this paper. And again, this is another study by a different lab, but using still the same tissue set. You see that these large vacuoles represent lipid droplets that were at the time described as foamy macrophages present in the human spinal cord. And these are chronically present. So these are decades out after injury. And so we wanted to get more at the mechanism, and to do this, we had to kind of develop a in vitro assay to kind of pursue some mechanistic questions that we had. And this is when Christine Ryan started in the lab. And so Christine, with the help of Hassan, who has been the kind of the high content screening guru at the Miami project, developed this kind of novel assay. So up until this point, how foamy macrophages were kind of mimicked in culture is that we would take primary bone marrow derived macrophages from typically mice, and then we'd grow them, and then we would incubate them in purified myelin. And then they would, accumulate these large lipid droplets inside the cells. And from those studies, ironically, it was concluded that myelin was the primary source, or probably really only considered as the only source of lipids in foamy macrophages. Of course, if you add myelin to macrophages, myelin is going to be the source, right? In atherosclerosis, you would add oxidized LDL, and obviously oxidized LDL is the source of lipids there. So we thought that was a kind of a weird and convoluted conclusions. So what we did was we took shiver mice that lacked myelin, and we performed both in vivo and in vitro analysis to see if those shiver mice that have almost no myelin would form foamy macrophages. And indeed they do, albeit to a lesser extent than wild-type animals, but certainly you can get foamy macrophages from non-myelin sources. So what we do is actually much simpler than the previous assay. We actually homogenize the spinal cord from mice, and then we just incubate the bone marrow-derived macrophages in the homogenate for 24 hours. And you can get this concentration dependent increase, accumulation of lipid droplets. So here, these green droplets are marked by Nile red, which also stains neutral lipids. And now we have this assay robust enough to use a high content screening assay, such a machine such as this new Phoenix Opera equipment that we have in our imaging core. And so Christine's first job was to look at kind of what are the consequences of this foamy macrophage formation in vitro. And so this was in collaboration with Carlos Moraes' lab, who was nice enough to help us use their seahorse assay. This is an assay now to test mitochondrial function. And so you can use inhibitors of the oxidative phosphorylation pathway to look at how that affects oxygen consumption rate. And in black here is kind of how a normal macrophage might behave. And then in blue here is the graph in the foamy macrophages. So as you can see, even before we start to add these inhibitors of the OXPHOS pathway, you can see that there's a baseline disruption of oxygen consumption rate. And then based on the differences between different parts of this graph, I don't really need to go into all the details. The point is that these different regions over here tell you different functions of different mitochondrial functions. And as you can see, homogeneous treated foamy macrophages have display dysfunctions of several mitochondrial function. And then this is associated with increased reactive oxygen species production as detected by mitosocs over here. And so in media, you have some mitosocs positive macrophages. As a positive control, we treat them with hydrogen peroxide. And then so a lot of macrophages now express reactive oxygen species. And then once you treat with homogenate, they also display increased reactive oxygen species production that's consistent with the mitochondrial dysfunction that we've shown in the foamy macrophage in vitro. Of course, this is also associated with increased expression of a lot of pro-inflammatory cytokines, as you can see on the right here. So these are expression levels seen in media-treated group. And then this is the expression level seen in homogenate. This is from it's a protein cytokine array that's a lot like an ELISA that's able to detect about over 100 different cytokines as a kind of a dot plot system. And so because we have a large kind of data set here, what we decided to do was analyze this using TEC pathway analysis to see what pathways might be responsible for the associated increase in inflammatory cytokines. And this analysis was done by James in the lab, and it led to 3 possible signaling pathways: the age-RAGE pathway, JAK-STAT pathway, and the PI3 kinase AKT signaling pathway. And so what we decided to do was take a kind of a chemical biology approach and then use inhibitors against these pathways and see how they might affect the foamy macrophage phenotype. Let's see, I think I have a question in chat. What assay? Yes, so I think I just answered that. I can send you the catalog number if you just send me an email, but it's a dot plot, basically. It's a protein array. It looks like a dot plot on a membrane. And then so you incubate that dot plot just like you would when you run a Western blot, and then use chemiluminescence to detect the intensity of the dots.
Thank you.
Sure. Okay. And so when we treated these foamy macrophages with the inhibitors of these three pathways, we identified Torin-2, which is a commonly used inhibitor of PI3 kinase mTOR pathway, that dose-dependently decreased lipid content in the foamy macrophages, as opposed to inhibitors of the AHRH pathway and the JAK-STAT pathway that had very minimal effects. And so that kind of, gave us our first quote-unquote hit compound taking this approach. and Torin-2 has been really proven to be a nice tool compound, to say the least, that has given us a lot of mechanistic insight into this pathway, as I'll show you in a little bit. So again, if you treat the foamy macrophage with Torin-2, you get a dose-dependent decrease in lipid content in the foamy macrophages. You also get a nice decrease in IL-1 alpha expression after Torin-2, with an associated decrease in reactive oxygen species production. So as you can see, we're staying with minosox again. Hydrogen peroxide, again, is used as a positive control. Interestingly, Torin-2 did not have an effect on hydrogen peroxide-induced increase in reactive oxygen species production, indicating that the effect of Torin-2 is not just a broad effect on ROS production, but seems to be, at least in this context, specific to foamy macrophage formation. And so because Torin-2 has a lot of different targets, this is now kind of where we've been getting into the target identification for Torin-2. Not only does it inhibit mTOR, but it also inhibits PI3 kinase and several other targets. So we took inhibitors that are more specific to those targets, namely mTOR, PI3 kinase, CLK4, CSF1, and we found that PI3 kinase was a strong candidate for Torin-2's effect. Interestingly, rapamycin, which preferentially targets mTORC1, did not reduce lipid accumulation in foamy macrophages, indicating that Torin-2 is likely not mediating its effect through mTOR, or that it's actually mediating through mTORC2 pathway in conjunction with the PI3 kinase pathway. And so this is kind of where we're at now, trying to elucidate the mechanism by which foamy macrophages are forming. We are pretty confident in that it's mediated by PI3 kinase activating PDK1, and kind of now all the arrows are pointing to AKT at this point, although we kind of need to do some more the gold standard genetic analysis to tackle this in more detail. But we are fairly confident that it is not being mediated by mTORC1 pathway. All right, so then what does Torin-2 do to in vivo? So one of the tools that we've used over the years to deplete macrophages, and this is a pharmacological approach that's been around for a long time in immunology, is to use clogenate liposomes. So these are liposomes that contain clogenate inside, and so they disrupt ATP synthesis. And then because when you inject liposomes systemically, they're preferentially taken up by macrophages in the peripheral organs. it's a nice way to deplete monocyte-derived macrophages in many disease contexts. And so we reasoned that instead of using clogenate, we can replace that with any other compound. And so we replaced clogenate with Taurin-2. And so we just had this made by a company. And when we injected that systemically, we saw a significant decrease, not only in macrophage number, but the amount of old red O that was contained within macrophages, as indicated by the quantification over here. So this was an endpoint of 7 days after injury, more of a proof of concept study to show that Taurin-2 can reduce lipid content in macrophages, in foamy macrophages after spinal cord injury. Now, the kind of disadvantage of using this approach is that at a certain point, monocytes stop coming in to the injury site because the blood spinal cord barrier reestablishes. And so now you can't use this Trojan horse approach to target macrophages. And so when you stop giving Taurin-2 liposomes about between 1 and 2 weeks after injury, and you take them further out, the foamy macrophages start to reappear. And so right now, we are trying to address this problem using novel drug delivery systems, as I'll kind of discuss a little bit later. And so this is kind of the approach that we've taken initially, right? Start with the transcriptomics data set, and then we'll go into our in vitro, identify some pathways and come up with a hit compound. This is probably more of a traditional hypothesis-driven approach that that's kind of more widely used. But I now want to kind of tell you about some couple of ongoing studies that are taking more novel bioinformatics and cheminformatics approaches to for hit compound discovery. One recent study that we've started in collaboration with Hassan Al-Ali is using a platform that he and the Lembics lab discovered a while ago called ID Tracks. Many of you are probably familiar with that by now. It's kind of a very popular story at the Miami project. And so Hassan and the Lembics lab use this platform. So it's a machine learning algorithm used to identify kinase targets. And so it starts with a phenotypic screening assay. And so in their kind of initial studies, they did hippocampal neurons to look at neurite outgrowth. And so they screened in that study, I think over 1,000 kinase inhibitors to come up with this profile of hits, of targets and anti-targets as indicated by hits, meaning they would induce a phenotype of interest, which in this case makes the neurites grow longer, and non-hits, which actually makes the neurite grow shorter. And so then that gave them insight into what kinase targets that they can inhibit, but also which anti-targets to avoid. And using this approach, they identified at that time this compound called RO48 that in vivo induced sprouting and growth of corticospinal axons after pyramidality. And so this has been very fruitful into their hands. There's now kind of derivatives of this compound that they've received a large blueprint for neurotherapeutics NIH grant for that's hopefully going to, with the goal of entering clinical trials in the near future. And so this approach is compatible with any phenotypic screening strategies that you might have. And since we had a nice foamy macrophage screening strategy to look at lipid accumulation of macrophages, we have now started this project with a grant from the Department of Defense. This is a project that's being spearheaded by Susanna, obviously in collaboration with Hassan's lab. And now we've just finished screening almost 400 kinase inhibitors, and we're now completed the screening phase of the study. These are dose response curves on the left here. Initially, this is now cell number. Obviously, we want to look at cell viability. And then this is the concentration of the compounds that are used. And so also on the left is 0 for vehicle. And then as you go to the right, it's increasing concentrations. Obviously, there are some compounds that induce cell death here, as indicated by less than 60% viability. And so we exclude that from further analysis to come up with all of these individual line being the dose response curve for a single compound. And then obviously we have the lipid droplet intensity data. And so these are all, obviously we have a lot of compounds that don't work, some compounds that do work. And so when we weed out the compounds that don't seem to have an effect, we come up with what we presumably would be hits. This is still up for further analysis here. This is kind of fresh off the press or hot off the press. And so now our kind of next strategy is to take some of these compounds, do some further validation steps, and then kind of feed this information of not only the hits, but also the non-hits, right? To look at what the targets and the anti-targets would be, and get to establish a more accurate kinase inhibitor profile which would hopefully then identify a potential kinase inhibitor that we would then take in vivo. So that's kind of the workflow that we have designed for this strategy. The next strategy that we're also working on is instead of taking the transcriptomics data, right, and then going to the in vitro assay straight from there, what if you can take the transcriptomics data and that can give you information of what compounds might work or not work, right? And so this is a strategy that we're taking advantage of this data set called the LINKS data set from the NIH. And basically what you're able to do, so this LINKS data set is a data set of, they must have screened, I think, between 30 and 40,000 compounds across hundreds of different cell lines. So they would take a cell line, treat it with vehicle or a specific perturbagen, and then get the expression profile of these 1,000 genes that they deduced computationally that kind of is a good indicator of the overall transcriptomic changes, right? So they've narrowed the entire transcriptomics down to these 1,000 genes. And that's kind of the profile of that compound in this single cell line, right? And so they've done this now for, like I said, for almost 40,000 compounds and hundreds of cell lines, and then made it available. And so now what you are able to do is input your gene, kind of your transcriptomics data. So in our case, we put in our macrophage RNA-seq data set of genes that go up and genes that go down, right? And then you can use this platform to identify compounds that are predicted to reverse or mimic this phenotype, right? Or this just transcriptomic profile. And then it will give you a list of compounds, based on some rank order. And it'll give you the cell line that was tested in. And so we took this approach to identify some potential compounds that might reverse the foamy macrophage phenotype. And again, this is a project that is spearheaded by Susanna, in this case, in collaboration with Nagi's lab, who's now at Georgetown. And so again, this is called the Library of Integrated Network-Based Cellular Signatures. In this case, we take the signature that we're using, right, is the foamy macrophage signature. And then you can identify compounds that are predicted to reverse this signature transcriptomically. So now what we're trying to do is reverse it from the 7-day transcriptomic profile to the 3-day profile, right? or phenotypically speaking, we're trying to reverse it from a foamy phenotype to a non-foamy phenotype, as indicated here. And so Susanna performed this analysis, came up with some top compound hits. She came up with 6 initially. And kind of the first job is to test in our in vitro assay to see if these compounds would, in fact, reduce lipid content in foamy macrophages. And based on those results, we would then go in vivo to see if that would hold true after spinal cord injury in vivo. And so of the 6 compounds that she tested, 3 were considered as hits, and 3 were not. Some didn't decrease the lipid content enough, or some led to, as you can see, cell death, indicating toxicity. And so of the 6 top hits that she identified, we came up with cholesterol, this LDN compound, and with afferent A, as showing very nice dose-dependent decrease in lipid droplet intensity in foamy macrophages without inducing significant cell death, right? And so if you, again, on the left here is the lipid droplet intensity. On the x-axis, we have the dose concentration in log scale. And then these are some representative images at each concentration that were tested for each of the compounds that we tested. And so these are some just representative images that are zoomed in. And so these are the foamy macrophages on the left. Again, we're trying to reverse that phenotype to a regular macrophages on the right. And as you can see, all 3 compounds had significant effects on the amount of lipid that are present in the cell. With afferent A seemed to have kind of the strongest effect in that not only did they decrease the amount of lipid droplets inside the cell, but you can see that the morphology of the macrophages actually also more closely resembled the morphology of regular macrophages that were treated with media. And so we took these cells, the compounds, these 3 compounds, and then tested them in vivo. What we did was she injected them daily from 3 to 7 days after injury. So this gives a large therapeutic window because the foamy macrophages don't start to appear until 3 days after injury. We have now 3 days before we can start to treat with these inhibitors to try to reverse the foamy macrophage phenotype. And so magenta here is oil-red-O staining. So you can see CD11B positive cells that are filled with oil-red-O lipid droplets. The first bar you see here is vehicle-treated animals, as indicated by this representative image on the left. And then, surprisingly, all 3 compounds seem to have some effect. Obviously, it's a bit underpowered, but again, this is 7 days after injury, just as a proof of concept study to see if the compound actually works and has the desired effects on foamy macrophages. And with afferent A, seemed to have the strongest effect, and it's not denoted here, but this is in fact statistically significant using one-way ANOVA. And then with a representative image from with afferent A is indicated here, over here. So this is a very promising start to using this large publicly available data set from the NIH to try to deduce compounds that might work. Now, the mechanism is still kind of unknown, right? And that's something that we have to address further down the road. But in this case, we're starting backwards. We're starting with the actual compounds and then starting to deduce the mechanism. But as you can see, the success rate is much higher than we would have actually ever hoped for. And so this gives us a much more efficient, I don't know if efficient is the right word, but a method of narrowing down hit candidates to take in vivo models. And so kind of where are we going with this further down the road? Obviously, we have to do some more chronic studies to see if this would manifest in behavioral and better histological function, and those are kind of in the works. But foamy macrophages are just one type of cell, right? That's present at the injury site. And so I showed you the complexity of the cellular heterogeneity that's present at the injury site. And you could imagine how this approach would be amenable for not only macrophages, but for virtually any other cell type in which you can develop a robust phenotypic screening assay. And so, we didn't want to just stop at the macrophages. We were interested in the transcriptomic profile of all the cells that are actually comprised at the injury site. And so recently, we kind of took on this challenge by using single-cell RNA-seq of the mouse spinal cord injury site. So this is using a 10x Chromium platform that's available both at the Cancer Center and at the Human Genomics Institute. And so basically you get a single cell suspension like you would do when you do flow cytometry of the injury site. And each cell is encased in a droplet that has a microparticle that has barcoded oligonucleotides that represent the entire transcriptome. And so because each bead has a unique barcode, when you then do a cDNA synthesis and a library prep, you can now trace that barcode back to the original cell bioinformatically. And this is kind of the pipeline that you go through. And in the end, using bioinformatics, you come up with this dimension reduction plot, as you can see here. So again, this is a recent paper that was published, spearheaded by Lindsay, who recently graduated, and by James. And this dimension reduction plot shows the relationship of individual cells in clusters. So each dot you see here is an individual cell, and that cell has about 2,000 to 3,000 data points representing the genes that are expressed in that single cell. And so then what the program does is to cluster together these gene profiles that are statistically deemed similar to each other. Now, obviously, the program doesn't know what a microglia is or a macrophage is. And so we go in with annotated markers. And so, and kind of back at the time, we would manually kind of identify this. There are now programs that would do this automatically now, because apparently, based on all these single cell data sets, the computer now knows what a macroglia is and what a macrophage is. And so this now represents really virtually all cells, all different cell types that are present at the spinal cord injury site. In the beginning, we didn't really know what we were going to get, but fortunately, the single cell suspension that we were able to obtain did in fact contain virtually all different cell types that are present at the injury site. Obviously, it's kind of represented more heavily toward the leukocytes because those are more amenable for single cell suspensions. And then what we do is we split this up into different categories. So these are now myeloid category. These are vascular cell category. And then these are now macroglial cell category. And then we can get more detailed information on subpopulation of cells. So instead of just looking at microglia, right, we can now break up microglia into microglia subpopulation that might serve different functions and contribute to pathology in different ways. And so these are ongoing projects right now. But the kind of what we're trying to do with this data set now is feed this into a Lynx type of a data set. And so this is a platform that's being currently developed by Nagy in his lab, looking at tumor cell heterogeneity in glioblastomas. And so he is in the process of being a platform that is compatible with single cell data sets. So now then you would put in the entire single cell data set, and then now you can identify compounds that are more specific for specific cell types. For example, reversing the microglia phenotype or the macrophage phenotype, so forth and so on. And so that's an ongoing collaboration we have with Nagy right now. And in summary, I thought one way that I could do the summary slide is I recently presented a part of this work at the last Asia meeting. And in that session, we are asked to have a summary slide that is kind of more friendly for the broad audience, especially the clinicians and people with spinal cord injury that might be in the audience. So this is kind of the format, and I thought it might be appropriate for the Grand Rounds talk. So the first question that they want you to address is, what are the potential benefits of this data to individuals with spinal cord injury? Well, I think that we've identified a new druggable pathobiology in foamy macrophages after spinal cord injury. So we think that's something that's important for individuals living with spinal cord injury, and that there are now multiple bioinformatic tools that can be used for a more efficient, quote unquote, efficient drug discovery process. Take-home points for clinicians is that foamy macrophages is a pathology that contributes to the chronic inflammatory state of the injury site and limits proper wound healing. And we think that this is mediated in part by the PI3 kinase and AKT signaling pathway. And so what are the next steps toward clinical translation? And so obviously we have to identify the compounds, right, that are most effective. We've identified several hit compounds now, but obviously we need to narrow that down to the ones that we think that might be most effective. And importantly, we need to devise a drug delivery strategy that would allow us to deliver this drug into the spinal cord at chronic stages. Because as I mentioned, if you stop giving the compounds acutely, the foamy macrophage phenotype will come back. And so, that's something that we want to prevent. Again, I want to thank the people who have contributed to this work, especially Susanna, who's spearheading a lot of this bioinformatics effort with help of Nagy and Hassan's lab as key collaborators, and as well as former graduate student Christine, and then also James, who's been really instrumental in the bioinformatics pipeline. Okay, I'll stop there and take any questions that you might have.
Thank you so much, Jay. What an exciting and very provocative talk, utilizing state-of-the-art methodologies to really dissect out the different cellular reactions that are occurring in this foamy macrophage story, and your hypothesis that it may limit proper wound healing after spinal cord injury or brain injury, if that matters. I think very, very exciting. So do you call this a potentially neuroprotective strategy, or would be more that would be involved in a more regenerative process as the spinal cord tries to repair itself, if you will, Jay?
Because of the timeline that it takes for the foamy macrophages to form, right? Starts to form around 3 days, and then it's really kind of high at 7. A lot of the cell death from the primary insult would probably have occurred by then. So I don't think this strategy would be considered neuroprotective at the acute stage, but it might be protective at the more chronic stages, when the chronic inflammatory response limits some of the cell types. So, but probably it's more of a regenerative strategy, because we think that the scarring process that occurs chronically kind of ties into this. And so by limiting foamy macrophage formation, we think we're going to reduce the inhibitory nature of the scar that would then allow things like axons and oligodendrocytes to regenerate better.
Very good. Thank you. Other questions or comments?
Yeah, I think this is a great talk, Dr. Lee. Our lab has done a little bit of work kind of using that LINX platform for glioblastoma. I think it's interesting that you can actually, look at different cellular transcriptomic states within the LINX platform, so you can stratify maybe specific for the cells that are enriched with your macrophage signature. So I think that's interesting. My question was, did you look into doing any kind of spatial transcriptomics, with these like newer pipelines, like for example in human spinal cord tissue, to see where these macrophages are in patients maybe?
Yeah, so we tried doing some of that with the tools that were available at the cancer center, and we started out with human tissue, because we were really excited and we were trying to use that tissue for that purpose. It's been a lot more challenging than we had anticipated, and so recently we started just going back to mouse tissue, rodent tissue, just to start the project, and then maybe once we get better at it, we would have better luck with the human tissue. So we did start the spatial transcriptomics study. We are using the 10x Visium platform, and so we've submitted our first sample and are waiting for the results back. But the idea there is that we would then combine the spatial transcriptomics with the single-cell RNA-seq data to be then able to tell, where the cells of interest that we're trying to target are located, because we think the location, either within the glial scar or within the fibrotic scar, would inform us about how to deliver the drug and where to target and things like that.
That's fantastic.
Jay, this is Ashu. Thanks for sharing your body of work, from basic discovery all the way now, getting into clinical translation. On the clinical translation aspect, this is a question I've had for Hassan also, are any of these hits, potentially patentable and licensable if you do optimize one of them and it turns out to be a good hit?
Absolutely. So Hassan has done that with the derivatives of the oral compound. So initially, you get obviously inhibitors that are already in existence, but you can do medicinal chemistry, right, to kind of modify them and make them more drug-like with better properties. And so he's certainly done that, and that's been kind of the cornerstone of his blueprint for neurotherapeutics grant that will hopefully, in which the end goal is to enter phase 1 clinical trial.
And I just can add that one of the major initiatives that we have at the Miller School of Medicine is developing a state-of-the-art drug discovery program, and we're we're really moving forward on that vision already. But within a year, we'll have a central located drug discovery program on the first floor of the Lois Pope Life Center. So there'll be experts to talk to, doing some of the things that Jay and Hassan and John and Vance and others have been doing. So it's exciting times in terms of utilizing these state-of-the-art approaches to identify new drug targets, and then actually trying to understand what drugs can be used to target these cellular molecular events. So exciting times. So if there are no other questions or comments, thank you very much, Jay. You take care, and everyone have a great day. Thank you very much.
Thank you.
Bye-bye.